Dr. Nathal is a dear colleague. Edgar, thank you for being here with us. He's a world famous brain surgeon leader, from Mexico originally, but he's really internationally known. He has done extraordinary contribution to literature, amazing amount of surgery. You can see just in one little approach how many surgeries he's done. He did his MD at the University of Guadalajara. Then he went on to do his internship, stayed in Mexico, did a residency in el Instituto Nacional de Ciencias Médicas y Nutrición in Mexico City. And then at the same institute where he's a leader now, he did his residency, his master's degree at the UNAM, what is called the biggest university actually in America. And then I would dare that is one of the biggest ones in the world. Maybe there are another one or two that are equally large. Then he went on to do a special training with Dr. Pernesky, who we know became the chief, the department coordinator leader, at a national, international level. These are extraordinarily important programs in the world with an extraordinary impact on the literature. You can see his H-index, his impact on the literature, and writing from his experience and contributing as contributor to several of our books that we have done in brain surgery and skull-based approaches. So today, at a personal level, I put this slide right here because it's been a tremendous honor for me. I follow his career since I was a resident and I graduated. I have followed his work. I watch him operate in different occasions. We have been together in several missions. I watch his videos as he presents some of his talks, and I'm always extraordinarily impressed, amazed, and at awe of all the things that he's doing, the way he also teaches his residents, the way he leads by example. So we are delighted to have you here, Edgar. I am going to stop sharing this right here so I can let you take it away. And we're delighted you're our last speaker of 2021. Take it away, Edgar, please.
Thank you very much. Thank you very much for the invitation to this neuroscience and neurosurgical lecture series of the Mayo Clinic. And I will like to talk today about the experience that we have get with the Miniterminal approach from the 680 cases that I have operated until the last year. So I want to start. I have no conflicts of interest to disclose, but I want to start with this drawing of Dr. Walter Dandy about the first documented clipping of a PCOM aneurysm. As you can see in this drawing, there is an exposition of the frontal and temporal lobe through a frontotemporal approach that has a little changes until the 70s, when Dr. Yasargil introduced the concept of microsurgery and the dissection of the subarachnoid tissue. And he described the terminal approach that is still in use for most neurosurgeons to treat anterior circulation aneurysms. This approach is based on the following the pathway between the brain and the sphenoid ridge until the basal cisterns and the anterior clinal process. This is a close-up view, but if we move into a surgical view, as we do after the craniotomy, we will see this triangular space that represents the sphenoid ridge. And this triangular space should be drilled away until the anterior clinal process to reach the basal cisterns and the anterior part of the circle of Willis. So I want to present one of my first cases that I did when I was starting the vascular neurosurgery. This is a case in which you can see a clot, a blood clot at the right side, at the basal part, corresponding to the presence of a PCOM aneurysm at this point. So I take this patient into the operating room and I perform what I was developed at that time, that was my concept of the terminal approach. This is the zygomatic arc, and this is the superior temporal line. So I extend the incision a little bit more than superior temporal line. And this is the craniotomy. You can see this is a little bit a small craniotomy centered over the sylvian fissure. And you can see here the frontal and temporal lobe. After opening the dura and splitting the sylvian fissure completely, you can see the final view of the operation, in which you can see the clip. I use this retractor only for demonstration of the picture because I usually do not use any retractor during my surgeries. But look, after the closure of the dura, I let this part of the dura without using. I realized that, and I then think how can reduce the amount of the craniotomy only to this part. This was my first thing about the Miniterional approach. This is the patient 6 months after surgery. And I want also to introduce here my mentors and also the examples of this kind of surgery. These are the pioneers of the minimal invasive neurosurgery. I had the opportunity to see Dr. Fukushima in Japan before he went into the United States. And this is Dr. Axel Pernesky. I traveled with Dr. Pernesky because I was very interested in the minimal invasive approaches. Dr. Fukushima has already published some of his concepts about the anterior communicating artery aneurysm, the microvascular decompression of the trigeminal nerve, and also the treatment of petrosal meningiomas through a keyhole approach. Dr. Pernesky also published 1 or 2 books at the beginning about the keyhole approach. And I have the opportunity to see all these approaches in my visits to Dr. Pernesky. These are some variants of the anterior approaches for anterior communicating and distal anterior cerebral artery aneurysms. This is the interhemispheric approach, the subtemporal extradural or intradural approach, the suboccipital approach, and the transciliar approach that Dr. Pernesky used to treat many aneurysms of the anterior circulation. To this part, I can add the concept of the Ministerial approach that I developed early in the 2000 year, and I presented some meetings about vascular neurosurgery. So this is this is a history. This is one of my first papers and presentations about the surgical treatment through the transciliar approach. This was a meeting in the 2000 in Matsumoto. The president was Professor Kobayashi, also very well-known vascular neurosurgery and skull-based surgeon. I presented at that time 35 aneurysms in 31 patients. After then, I returned to Mexico and I start to use another keyhole approach. This is the subtemporal extradural for trigeminal neurinomas. This is one example of these cases. This is another example in which the neuronoma extend into the posterior fossa. This is the preoperative and postoperative image using this small keyhole approach. I also try to use the suboccipital approach that is actually a direct pathway to the supracerebellar infratentorial approach for pineal region tumors. These are 2 examples of this, the use of this approach and the surgical results using this keyhole axis. This is another example using the different approach than the Ministerial approach. This is the anterior interhemispheric approach for distal anterior cerebral artery aneurysm. So with this experience, with these keyhole approaches, I decided to go further. And this was a small Ministerial approach that I showed in my first case, but I wanted to advance to a smaller keyhole approach directed over the sylvian fissure to go directly into the basal cistern. The goal was to obtain through a very directed keyhole approach the space enough to treat any aneurysm located at the anterior part of the circle of Willis. The anatomy, I analyzed the anatomy of many dry skulls, and you can see here the Therion area, and there is a depression over this area that represents the location also of the sylvian fissure. This is very constant from one skull to another, as you can observe. So this terminal area represents the external figure of the sphenoid ridge. So this Therion is directly related with the sphenoid ridge, and then is related with the sylvian fissure. So if we follow this line, that is the sylvian line as described by Professor Rotten, you, in any part of this line, you can reach the sylvian fissure. And if you go in the proximal fashion, you can then go directly into the most proximal part of the sylvian fissure, and then you are going very near to the basal cisterns. This is the final concept I get. This is the craniotomy, a small 4 by 3 centimeters craniotomy with a burr hole located at the most distal part of the exposure. And this triangle, this black triangle, represents the area that should be drilled away during the surgery. In this, by so doing, you can get a very appropriate space to dissect and to locate any aneurysm at the anterior circulation. This is an example of how I plan this incision. You can see I shape only 1 centimeter behind the hairline, and this is a small incision, about 5 to 6 centimeters. This is the zygoma and the beginning of the superior temporal line. If you want, you can extend the amount of incision according to the aneurysm. For example, for PCOM aneurysms, I used to extend more to the temporal lobe, and for anterior communicating artery, I extend more the incision into the frontal lobe. This is the first case I treat by this approach. This was a patient with mirror aneurysms of the middle cerebral artery. So we decided to prove our concepts to treat this aneurysm. I was working together with Dr. Juan Luis Gomez Amador. He was a resident at that time. And this is the post-operative view of the angiography, that you can see that all the aneurysms were totally clipped. These are pictures of our first case. You can see here the small opening over the dura. This is the final post-operative view, which you can see the size of the craniotomy and the position of the clip. And this is the picture 1 month after surgery, and 6 months. You cannot see actually the incision, and the cosmetic results were very, very good. So I present my first small experience in 2001 in a minimal invasive neurosurgery congress. The president was Dr. Pernesky in Cairo, Egypt. And at that time, we presented 12 aneurysms in 10 patients with using this small approach. I also, at that time, was performing the transiliar approach with a higher number of patients, but I focused then over the Miniterminal approach. That is, I will show you how we made this approach. This is the anatomic reference I showed before, the craniotomy and the drilling of the sphenoid ridge, then the planning of the incision at the hairline, the wrapping and the marking of the skin. This is the skin, and you can see here the temporal muscle. I made a semicircular incision over here to expose the skull, and this is the burr at the most distal part of the craniotomy. And after then, with a bone chisel, we open and we direct the cut over the sphinal ridge to get this small piece of 4 by 3 centimeters. After then, we open the dura, and we are just in the center of the sylvian fissure. We split completely the sylvian fissure, and this is an example of a middle cerebral artery aneurysm with a broad neck. After clipping this aneurysm, we put the bone flap again, and this is the closure of the muscle, temporal muscle, in a very tight way, and this is the final skin incision. So this is the technique we use actually, and this was the technique that we published in 2005 in the first number of operative neurosurgery. These were the pictures in black and white, as I show you in the video. But I was reluctant to use the term of miniterminal or microterminal approach as we describe this approach in these early times, because there was some reluctance to use small approaches. In this paper, Dr. Spetzler and Peter Nakaji and Dr. Yasarji were the commenters of the paper. And you can see both comments are about the hesitation to use small openings to treat aneurysm. They were more proclive to use a big approaches. So I was right to be reluctant and to hesitate to name the miniterminal approach. But look, after 2 years, Everbal Figueiredo from Brazil reported the miniterminal approach with this name, and one of the authors was the same Robert Spetzler at that time. So you can see it's almost the same approach, but the only difference is that the temporal muscle is open in a way that similar to the interfacial dissection. So they move the temporal muscle to the lateral part. And this is the only difference that gives you a little bit more space behind the sphinal ridge. This is the closure, a little bit bigger incision that I use, but this was also described for using in tumors. This is the picture showing the size of the standard terminal approach and the size of the miniterminal approach, according to these authors. After then, Dr. Mura from Chile has used this approach for treating skull-based surgery tumors from the anterior, middle, and posterior fossa. You can see here how the incision extends into the frontal part of the bone, and they only use this small part of the craniotomy to perform the miniterminal approach. This is an extradural view of this approach as Dr. Mura used. But you can see here one aspect that causes me some doubts. You can see here the mini craniotomy and the incision. The incision is like any standard terminal approach. The craniotomy is reduced and there is some part of the bone that is not work. So this is very similar to me for my terminal approach that I use in my early years as vascular neurosurgeon. So there is no difference in the size actually. So for me, this is not a miniterminal approach. The miniterminal approach should be reduced to this part. However, this is only a concept because you can see some reported miniterminal approach in the literature, but you can see how if you open such amount of tissue and you use only this, for me has no sense because if you work all this tissue, you can make perfectly a bigger craniotomy to expose a standard pterygium approach, not only a mini craniotomy, letting a great amount of bone, pericranium, and muscle is free of working. So I'm not in agreement with this concept. This is another surgical approach described by Professor Herneniemi. Is a little bit higher, and the exposure is subfrontal. This Dr. Herneniemi has operated a lot of aneurysm through this approach very successfully. So it's also an approach acceptable for treating cerebral aneurysms. This is a comparison of the standard pterygium craniotomy with the Miniterminal approach that we use at present. Both cases are from our institute, but we have reduced the amount of the craniotomy without putting in risk the patient with very good results. At the final, the Miniterminal approach should complete all the surgical principles required to treat aneurysm. That means a safe dissection of the aneurysm, preservation of perforators, veins, and nerves, and the complete exclusion of the lesion from the general circulation without risk to the parent vessels, avoiding neck remnants. If the approach fulfills all these requirements, then you can use it for treating cerebral aneurysm. This is a video in which I am showing you how this works. This is after opening of the dura, and we are splitting now the sylvian fissure. This is a requirement if you want to use this approach, because no retraction is possible, because there is no space for retractors or retraction without splitting the arachnoid tissue. Here is the dissection of the proximal third, the biecula of the sylvian fissure. I will go ahead. And now we are working the basal cistern. See, this is the optic nerve, the anterior cerebral artery. This patient has had two aneurysms, one of the internal carotid artery bifurcation and a second one of the middle cerebral artery bifurcation. This is the complete opening of the arachnoid tissue. This will permit you a wide space without retraction, as you can see, to explore all the circle of Willis. This is the identification of the aneurysm. I tried to clip at the first attempt with a semi-curved Yashargil clip, and you have to be aware of these small perforators that arise at the side of the neck. Finally, we go for the second aneurysm. You can see a wide neck, and there is an artery adherent to the dome of the aneurysm. I tried to expose the 360 degrees of the MCA aneurysm before clipping. So I separate this small artery, and then we clip with a curved clip that will take all the neck of the aneurysm, as you will see. And after then, I coagulate the dome of the aneurysm, and the surgery is finished. This is the final coagulation to disappear as much as possible of the dome. You can see the final view after clipping. And after then, we close the dura, and the bone flap is positioned again. And I will show you very quickly some examples of use of this approach. This is on rupture left PCOM aneurysm. You can see the aneurysm, small neck, the planning, the post-operative angiography, and the patient after surgery and before discharging from the hospital. This is a rupture dorsal distal paraclinoid aneurysm. You can see the separation between the neck and the ophthalmic artery. This is the post-operative view in the patient at the external consultation at our hospital 6 months after surgery. This is another unruptured fusiform internal carotid artery bifurcation extending into the M1 segment of the middle cerebral artery. You can see here the 3D reconstruction after clipping and the angiography after clipping, and you can see how the clips were arranged to obliterate completely this fusiform aneurysm. This is the patient at the outpatient clinic, and you can see that these aneurysms are 2 or 3 centimeters from the surface. So these are very easy to locate and to clip in any condition, even when the aneurysm can have a very complex configuration. This is a unruptured anterior communicating artery aneurysm. These are the most difficult to clip by this approach because you have to extend the approach into the near to the superior temporal line to go under the frontal lobe to reach the anterior communicating artery complex. And this is the post-operative view in the patient before discharging from the hospital. Now we are seeing some cases of rupture. This is a paraclinoid dorsal type aneurysm. This patient has also a renal failure. He was under hemodialysis and working in the United States. He went on to vacation to Michoacan States in Mexico, and at that place he suffered a rupture of this aneurysm. So the patient doesn't want to return to the United States to be treated. He wanted to be treated here in Mexico. So we made this approach. You can see after emerging from the anesthesia, how he's moving his left side after being approached by the right side. That means that no deficit was induced by the clipping of the aneurysm. This is another case, special case, because it was a common PCOM aneurysm, but this patient was Jehovah's Witness. So there was some reluctance for another surgeons to operate because the risk of bleeding, but fortunately for the patient and for me, there was no problem during surgery and the aneurysm was totally clipped successfully. This is a difficult case to decide. This reminds me the first CT scan example that you show with the hypoxic case, but you can see here how the distribution of the subarachnoid hemorrhage is very symmetrical. Angiography showed mirror aneurysms at the middle cerebral artery, and you cannot decide easily which side was the rupture one. So we can use these approaches in such a way that you can plan both sides at the same surgery. This is the left side. This is the right side planning. After finishing the surgery, you can see here the incision on the left and the right side, the wrapping, and the patient after 6 months without a deficit and also with a very good cosmetic. So the advantage is that by reducing time, you can operate more than one aneurysm in one stage. And this is another example of this. This patient has a mirror MCA aneurysm and a ruptured distal anterior cerebral artery aneurysm. So in the same stage, we operate both sides, and through a mini anterior interhemispheric approach, all the aneurysm were totally clipped in one stage. This is one of the advantages of using a keyhole approach. There are some examples that you have solved during surgery. This is a PCOM aneurysm, left PCOM, but you can observe how the ventricles are enlarged. So we decided, because the patient was in a very good neurological stage, so we decided to operate, but we found a turgent brain. So in these cases, I use the puncture through the penis point to drain the CSF. After this maneuver, the brain becomes very, very soft, and we can proceed to opening the lamina terminalis cistern and to clip the aneurysm without any problem. So I can say that until now, by very good selecting of the patient, I have never moved from a miniterminal to a standard terminal approach. Now, there are many emerging experiences, especially in Asia, when in Japan, Korea, and China, where many series are emerging about the using of miniterminal approach. In this case, for cerebral aneurysms, the most used approach are the transiliar and the miniterminal approach at present. So I want to finish my presentation showing you the experience that we have get until now with 578 patients. Most of the cases belong to or were located at the middle cerebral artery, followed by the PCOM segment of the internal carotid artery. There is an important number of paraclinoid aneurysms. And now we are using the extradural approach through a miniterminal approach to clip these aneurysms in a very safe way, and also reducing the surgical time. This is the remaining ACOM, bifurcation, anterior choroidal artery, proximal anterior cerebral artery, and one aneurysm, truly PCOM aneurysm arising from the proximal part of the posterior communicating artery. We have a total of 681 aneurysms clipped until now, from the 2000 to 2020. And in this series, almost 18% of our cases were multiple aneurysm. So we have in our series of 578 patients, we have 681 aneurysm. The result, the final results are different if you consider the rupture and rupture aneurysm. For rupture aneurysms, the morbidity remains about 28%. I have to say that many of this morbidity is reduced to almost 11% in the first 3 months, because many of this morbidity is related with the surgical approach. And the mortality for rupture aneurysm is about 7.5%. However, for unruptured aneurysms, the morbidity is much lower, is 8.6%, and the mortality remains less than 3% according to the international standards. We have a rate of 96 of total clipping as demonstrated for angiography or CT angiogram. So in conclusions, we can say that the miniterminal approach, also known as terminal keyhole approach, is an alternative of treatment for anterior circulation aneurysm with less surgical time, bleeding, and hospital staying. Also, I have to say that most of the times the patients are very, very satisfied with the results, cosmetical results of the approach. It can be used for treatment of bilateral aneurysm in one stage. It requires, obviously, surgical training and skills. And I can say that the success of the keyhole surgery in general truly relies on the proper patient selection. This is the main pearl, the main message that I can give to the resident and all neurosurgeons that want to treat aneurysm using a keyhole approach. I invite you to search to see my channel in YouTube, in which I have a lot of vascular surgeries, including AVMs, bypass surgery, brainstem cavernomas, and obviously a lot of aneurysm in this channel. Thank you very much again for the invitation. And if there is any comment or question, I will be very happy to answer it.
Beautiful. Thank you, Dr. Nathal. Edgar, beautiful talk. You see a lot of comments on the chat about your work. You know, I'm going to ask JP, Dr. Almeida, who trained with Evandro de Oliveira, who's a dear colleague. Unfortunately, we lost him. We all know, but you know, he had some thoughts, you know, during his career and the later part of his career. And JP has beautiful thoughts and memories of spending time with him. JP, you want to comment about this and professor's thoughts?
Yeah, thank you, Dr. Nathal. Congratulations for your beautiful talk. Really excellent results. Congratulations. So just as you presented, like our impression as well is that we've been moving away from the, let's call like maximally invasive approaches to the more minimally invasive approaches. And it's interesting because my journey with Evandro started around 2009. And at that time, we're still like doing, you know, many pretemporals, orbital zygomatics for some of those aneurysms. And at the end, like around 15 to 17, we were moving all the way to Miniterionals, eyebrows, and even like moving a bit away from the interfascial dissection that we used to do a lot. So we fully agree with the experience that you have built over the years. The one point that I think is very important, and Dr. Oliveira also would always comment as you presented, is the case selection. That's really what will distinguish how you're going to manage those cases. So congratulations on your beautiful presentation. And we fully share your same sentiment about this approach.
Thank you, JP. We go from Brasilia. Now we're going to go to Colombia with Gabriel. Dr. Vargas, you want to comment all the way from Bucaramanga?
Thank you very much, Dr. Nathal. Thank you very much for this excellent presentation. We were also contaminated by the keyhole approaches by Dr. Pernesky. At that time, we developed that kind of surgeries, transciliar approaches and minimally invasive, and it's excellent that somebody keep that constant concept in order to introduce we as neurosurgeons for that kind of minimal invasive approaches, because we are really competing with the endovascular treatments. So we need to do an excellent surgery, and this is one example of how minimal invasive surgery is doing with excellent results. One question, Dr. Nathal. Facial nerve situation, frontal branch of this nerve from this approach, any pearls that we can keep in mind in order to preserve that facial nerve, because sometimes we may damage that in these kind of approaches. And thank you very much.
Yeah, thank you very much, Dr. Vargas. Yes, as you notice, I do not use the interfacial dissection. I use the cutting of the muscle behind the frontal nerve direction. So I sometimes I have some problem with the facial frontal branch, but usually it's temporarily because you never face directly the nerve. So the possibility to lesion, to cause a lesion of this nerve is very low. This is one of the advantage of the approach. And the other thing that I was not very insistent is in the absence of the hollowing, the temporal hollowing that follows most of the times the interfacial dissection, because you separate the muscle, you put again, but if you don't fix totally, the nerve suffers hypertrophic, and then hollowing in the long term is very visible in many of these patients.
Beautiful point, Edgar. Beautiful, great question. Gabriel. So I'm going to pivot right now to Dr. Montesser, who spent time in Ohio State and then at the Harvard program. And then I'm going to end up with one comment and question from Robbie Talk. So Ala, you want to take it away? One of our residents, Edgar, right here, who also spent some fellowship before coming to us. Go ahead, Ala, please.
Sure, thank you. Thank you, Dr. Nathal, for such a wonderful presentation and kind of like viewing all these efforts to kind of like develop and push the Miniterminal approach and the other keyhole and the keyhole surgeries as well. Actually, I'm fascinated by the keyhole approaches, and I've seen it with Dr. Provedalo and Dr. Kraubeck and OSU, and yeah, it is wonderful approach. But as you mentioned, you have to be well trained to know how to do it, and this is what I've learned from them, as well as the patient selection. I'm echoing your thoughts and JP's thoughts as well. And to be honest, in all the places that I've been trained in, whether in OSU or at Brigham and Women's Hospital with Dr. Laws and Boston Children's Hospital as well, I've learned that the patient selection is a key success to have a good outcome. Another very important thing that I've noticed from your presentation is your persistence on developing the approach and kind of like keep on pushing that approach and modifying it gradually over the years while keeping the safety of the patient and the optimum outcome that you can approach. So thank you so much for this wonderful presentation.
Beautiful, thank you, Ala. And we'll end up with Robbie so that we can have a few minutes to meet Edgar. You and I saw that Andres put our schedule right there for you to have some meetings with the faculty, residents, and fellows. So Dr. Talk, take it away, please.
Great. Dr. Nathal, thank you so much for this outstanding presentation. I know of you a lot, basically, but this is my first pleasure to meet with you virtually now and learn more about your cases with your presentations and videos. So number one, this is a great testament to the residents and the new generation that microsurgery has evolved, because some criticism have been that nothing changed, and then people show how many coils have been invented since the 90s, and then people say nothing has changed, we still use the microscope and the clips. But yes, individualizing those approaches makes a big difference. And no surprise, I did not know you spent time with Dr. Pernesky, whom I know about as well from my mentor, Dr. Walter Grant, who spent time with him and who used to go and learn from him. And he always spoke so highly. And no surprise that why you thought about minimally invasive, because you followed the lead steps of those giants who started those. I don't want to extend the time, but your approach is like finger on the pulse, basically, because when we expose for those sterionals, I mean, we end up seeing 5-inch surface of the frontal lobe and 3-inch surface maybe from the middle, from the temporal lobe. For what we really need is just to open the sylvian fissure. So you have tailored your approach just to strictly what you absolutely need to get the case done. The question would be, how would you tailor this for an ACOM a little bit, MCA a little bit? And the second question, you showed that MCA bilateral clipping, that you clipped both MCAs, and we all have been in those situations where we don't know which aneurysm bled. But you also alluded towards the end of your presentation that you have been attempting contralateral. I've tried contralateral approach. It is intimidating how deep. Can you tell me about your experience trying to reach to the other side from this approach as well?
Well, I really don't like to approach the contralateral aneurysm except for the paraclinoid aneurysms, in which you can reach perfectly the other side. But for MCA or another aneurysms, I prefer to use the standard terminal craniotomy. This is part of my planning. If I want to, for example, if you have a MCA aneurysm on one side and very short M1 segment on the other side, I can try to contralateral approach, but using a standard terminal approach. Otherwise, I can clip both aneurysms with two different surgeries. I mean, at the same stage. I perform one surgery on one side, and after finish, I move the patient to the other side, and I complete the second operation. The time that it takes me to operate both aneurysm is the same that I use in a standard pterygiumnal approach. So these approaches are very quickly. I can be at the middle cerebral artery, for example, in 25 minutes after initiating the surgery. So very, very near from the surface, the MCA. So you can do both surgeries in a very short time.
Amazing. And maybe last question, I know we're beyond time. What is the future direction in Mexico? How do you see that we can preserve this art of microsurgery, knowing how endovascular is progressing at a fast pace, and as well knowing that many other subspecialists, other neurosurgeons are also participating in treatment of aneurysm?
Well, there is a economic issue in our countries. For example, the endovascular devices are more expensive outside of the United States. So the treatment is very, very cost for the institutions. So in public institutions, still 70% of the aneurysms are clipped. So the vascular neurosurgeon not only clip aneurysms, also is related with the ABMs, bypass surgery, cavernomas. So the future of the vascular surgery is still very promising in our latitude. So if the vascular surgeon finish, then what will happen with such a complex aneurysm that sometimes endovascular therapy could not solve? So I'm very, very optimistic about the future of the vascular surgery. At least, as you said before, we have seen the evolution of the endovascular devices since the 90s, and even now, still the recanalization of the aneurysm is present. And this is related not with the technique, not with the device. It's related with the hammer, water hammer shock over the internal part of the artery. So the clipping is treating the aneurysm from the outside. So the long-lasting duration of the clipping has been demonstrated in many series in all the multicentric studies that is more effective than the endovascular. But I don't want to touch this point because it's very controversial. But at the final, I think that there is a place for the vascular surgery at the long time. It is what I can say about it.
Beautiful. Well, thank you, Edgar. Great comments, Robbie. Beautiful. So we conclude our presentations. As you can see, Andres put the schedule for Dr. Nathal. He was kind and gracious enough to join us for some meetings. I'm going to be with him for a few minutes. I know him very well. And then the fellows are going to join us. I'm going to move out of that meeting to another meeting. And that's going to be from up until 8:30. At 8:30 to 9, he's going to meet the research fellows, the postdoctoral fellows. From 9 to 9:30, he's going to be meeting with the residents. And I look forward to residents, please take advantage of this world figure with so much experience. And of course, I look forward to our residents one day coming to visit with you, Edgar. I know that we're trying to build bridges with your residents also to come and visit with us, and us going through Mission Brain at your center to do something in the year 2022. Then from 9:30 to 9:40, he is going to meet with our residency director, Dr. Chaichan and Dr. Chen. Please talk about those ways of building bridges, our residents exchanging. 9:40 to 9:50 with our vascular surgeons, Dr. Tuck and Dr. Fox. Please talk about how we can build bridges in research and education. I love to have Edgar involved in the Rotan course, Ravi. That will be terrific. And our stroke conference also that we organize. And then 9:50 to 10, he's going to be meeting with our associate surgeons, Dr. Wessel and Dr. Almeida. So overall, we have a great morning with you, Edgar. We're so blessed. We're so grateful. The last talk of the year, we couldn't end in a better note. Amazing inspirational work. The year just came so fast, and we're looking forward to 2021. More events to come over the next few weeks. We don't have lecture series over the next 2 weeks. You know, we sell reminders. We'll continue to send reminders, but we are so blessed to have everybody here. It's been a tough 2 years in so many different ways, but I think that everybody's excelled in ways that cannot even be put on words. So thank you, Edgar. I'll see you in a few minutes. You have the other link. We're gonna move to that link and meet.
Can I leave only a final message
Yes.
that I forget? Only 1 minute, please.
Please.
This is for Latin American neurosurgeons, young neurosurgeons and neurosurgeons at all. We will perform the first bypass cerebral course on cadaveric specimens. We have developed a very interesting model using a pump, like in another place in the United States, trying to simulate the pulsation of the arteries and the aneurysm. And this will be performed from the 24th to 27th of February next year. Thank you very much.
Beautiful, Edgar. If you don't mind, we'll ask you for that slide and we'll promote that in our faculty. I don't really brag about our consultants, but I had the pleasure of working with Mike. I wrote several papers with Mike Lawton when I was a resident at UCSF. I traveled around the world with him, but I've seen Robbie operate on these bypasses, and I can tell you, I never seen someone. I feel like I'm watching Michelangelo when I watch him, operate on these bypasses. There's some beautiful. Hopefully, he'll show you some of his cases. But I'm just so proud of the work that both Robbie and Chris are doing from the up and in the vascular. I saw Dr. Miller and Dr. Wien as well right here. So they're going to meet with you. They're going to show you, but send us that slide and I'll promote it here from our side around the world. All right.
Okay.
I'll see you in a few minutes. Everybody.
Bye.
Great
Thank
day.
you.
All righty. I'll see you, Edgar, in the next meeting.
Congratulations.
Bye.
Excelente
Thank you.
charla, Edgar.